Hello everyone and welcome to my beginner's guide to paediatric chest x-rays. My name is Dr. Ben Fleming. I am a radiology ST5 with a subspecialty interest in paediatric radiology, working at the University Hospitals of Leicester. By the end of this session, I would like you to have begun to develop a systematic approach to a paediatric chest x-ray, to be able to name the common lines and tubes used in paediatrics and understand the basic principles behind their placement, and to understand the basic principles behind common pediatric chest x-ray abnormalities. I will illustrate these principles using the images of a wide range of disease processes, but due to the nature and duration of this talk, I'm not going to go into any great detail about any single disease process, but hopefully the images and brief discussion will stimulate you to do your own private reading. As we go through the presentation, you might find it useful to pause the video and have a look through the images yourself before I discuss the findings. It is important to develop a systematic approach to any imaging study, and the chest x-ray is no different. During a brief Google search, you'll see a multitude of patterns for interpreting a chest x-ray. For the purposes of this lecture, I have chosen a relatively simple and easy to remember pattern. The order goes: patient details and adequacy, lines and tubes, A for airway, B for breathing/lungs, C for the Cardiomediastinal Contours, D for the diaphragm, and E as a catch-all for everything else, including the bones and soft tissues. We will go through each of these in turn as we progress through the presentation. This kind of pattern is most useful for the seemingly normal X-ray. Ultimately, when you get more experienced, it's not this clear-cut, and you'll be assessing these components in a more pragmatic order. For example, it makes sense to talk about B before A in context of a large pneumothorax or whiteout. In an exam setting, if a chest x-ray is obviously abnormal, you should address the abnormality. An examiner is not going to be particularly impressed if you keep avoiding talking about an obvious abnormality for the sake of going through the pattern in order. But once the main abnormality is described, go back to the pattern so you do not miss a second abnormality. While we're on the subject of the normal chest x-ray, I would like to mention the thymus. The thymus is a T-cell producing lymphoid organ in the anterior mediastinum and is a normal structure in pediatric patients. It starts large, involutes with age, and has a bilobed structure. When you read textbook descriptions of the thymus, they often make reference to its wavy border. In my experience thus far, this isn't well seen. However, the image that is on the left side of the screen is about the best example I've seen. So take a look at the left border of the thymus here, which has a wavy appearance. On the left here, there is a diagram from Teach Me Anatomy, which illustrates the bilobed structure. And on the right, there is another x-ray of the normal thymus, where the inferior border can look sharp adjacent to the horizontal fissure of the right lung, but the thymus should not be lifted off the mediastinum at its medial border. In this example, both lobes of the thymus are lifted off the mediastinum by air within the mediastinum itself. This is called pneumomediastinum and is not infrequently seen in neonates. It is idiopathic and often requires supportive management only. This is a similar case. Again, the two lobes of the thymus are lifted off of the mediastinum, and in addition, we have the continuous diaphragm sign, whereby we see the entire contour of the diaphragm due to adjacent air. We do not normally see this sign due to the interface between the heart and the central cross of the diaphragm. The CT on the right is from the same case and shows a large volume of air within the pericardium and mediastinum as a whole. Okay, now let's go back to our standard pattern of interpretation. The first thing you need to ask yourself is, have I got the right patient? Because if not, everything that comes after is irrelevant. We often reel off the date of birth of the patient without thinking when we present adult x-rays, but it is far more important in pediatrics because it can have a huge impact on your differential diagnosis. You shouldn't be calling respiratory distress syndrome in a term neonate, as this is very unlikely outside of the context of gestational diabetes, and conversely, you shouldn't call meconium aspiration in a preterm neonate, as meconium passage is very uncommon in preterm deliveries. You must also consider the projection, which is typically AP or anterior-posterior in neonates and younger children. By anterior-posterior, I mean that the child is facing the beam. The beam is divergent and will typically overestimate the heart size. A cardiothoracic ratio of less than 60% in a neonate is considered normal. If a heart is of normal size on AP, then it is normal. But be aware of calling cardiomegaly unless the heart is grossly enlarged. Finally, always check the side marker, as you do not want to be caught out by dextrocardia. In reality, you will always have a patient date of birth for reference in the corner of the image, but in an exam situation, we don't necessarily have this available. The best way of telling whether a patient is pediatric is to look for the growth plates in the proximal humeri. As an extension of this, to tell a term from a preterm infant, the key places to look are the subcutaneous fat and humeral heads. Preterm babies have generally got less subcutaneous fat and unossified humeral heads, though this is not a hard and fast rule. If a patient has an umbilical cord clip or catheter, then they will almost invariably be under 2 weeks of age. Here we revisit our Thymus image from earlier on. Notice that the child has ossification of their humeral heads, suggesting that they are at term. You would be forgiven for thinking that there is nothing significantly wrong with this image, but please note that this image has been erroneously flipped. And actually, the appearances represent dextrocardia. In addition, there are further findings, including that the gastric bubble is also on the right side, and there is coarsening and thickening of the lower lobe bronchi in keeping with bronchiectasis. The underlying diagnosis in this patient is primary ciliary dyskinesia. I won't dwell on adequacy as it's covered extensively elsewhere. The easiest way to assess is to be systematic, starting with rotation, followed by inspiration, inclusion, and penetration, or RIIP. Adequacy is typically an issue in the very young and sick. Rotation and movement is common in peds, and the degree of inspiratory effort is often random, so making an assumption about the degree of hyperinflation is very difficult. Now we're going to move on to lines and tubes. This is by no means an exhaustive list, but these are the lines and tubes you'll encounter most frequently. Umbilical lines are included because in neonates we often x-ray the chest and abdomen together. Even if it's just the chest being imaged, you'll likely see the tips of the umbilical catheters, although you may not necessarily be able to tell an umbilical arterial catheter from an umbilical venous catheter unless you see the entry point, and we'll talk about this more later. The endotracheal tube is probably the most important tube, as if it is poorly positioned, the patient can deteriorate rapidly. The optimum position is 1.5 centimeters above the carina, although this is dependent on neck position and rotation. For radiology trainees, we are trained to say that when the tube is misplaced, that we would contact the clinical team immediately. In your exams, if you come across an X-ray of a misplaced tube, you need to illustrate that you are safe to practice by escalating it appropriately. Therefore, you should say something along the lines of, I would contact my senior immediately. Remember that if you are unsure as to the position of any tube, you can always contact a senior doctor, or if they're uncertain or unavailable, the on-call radiologist. In this image, the endotracheal tube has been pushed too far, and the tip is projected over the right main bronchus. The next thing to assess is whether there's any lung collapse as a result of preferential aeration of the right lower lobe. Fortunately, in this patient, there was no lung collapse and the tube was repositioned with no complication. Misplaced nasogastric tubes are a huge source of clinical incidence. The tube should descend in the midline, bisecting the carina with its tip below the diaphragm and beyond the gastroesophageal junction. The position beyond the gastroesophageal junction is often overlooked, but is important, as if the tube is above the gastroesophageal junction, then this can lead to reflux of feeds and subsequent aspiration. If the tube is in the correct position, then document in the patient's notes, along with a statement detailing that it is safe to feed. If the tube is incorrect, then let the patient's nurse know that it is not safe for use and contact a relevant senior. In this example of a not-so-paediatric patient, the nasogastric tube has coiled within the left main bronchus before entering the right main bronchus and is clearly not safe for use. There is loss of the left hemiphrodiaphragmatic contour in keeping with a left basal pneumonia. In this example, we are back to a paediatric patient. The tip of the nasogastric tube is clearly within the stomach bubble, but one of the side holes of the tube is projected over the distal esophagus. The tube should be advanced further to reduce the risk of reflux of feed into the patient's lungs. There is also some right upper zone opacity suggestive of infection. This image shows a very classic appearance. The nasogastric tube is coiled within the neck, which is highly suggestive of esophageal atresia. There is air in the stomach and small bowel, which means that there must be a fistula between the trachea and esophagus distal to the atretic segment. There is also diffuse granular opacity, suggestive of respiratory distress syndrome, which we'll cover in more detail later. Now we're going to talk about umbilical arterial catheters. The umbilical cord typically contains 2 arteries and 1 vein and can be cannulated to provide intravenous access. The acceptable positions are stated on the slide. The UAC positions were decided with the goal of avoiding placement of the tip away from the celiac axis at T12 and SMA at L1, in case thrombus at the catheter tip causes vascular occlusion. This is a diagrammatic representation of the course of the umbilical arterial catheter, or UAC for short. Upon entering the umbilical arterial line, it takes a dip and then ascends via the internal iliac artery and then up to where it finally resides in the descending thoracic aorta. The dip that it takes on entry is the most reliable way of distinguishing it from an umbilical venous catheter, or UVC. This is the same image from 2 slides ago. This image has several tubes, an NG tube, a long line, and a UAC. The UAC, which is seen to dip and ascend into the right internal iliac artery, has its tip projected over T7, T8. The tip of the nasogastric tube is within the stomach, and the right lower limb long line tip is projected over the intrahepatic IVC. We know that this is a long line rather than a UVC, as we can see it ascending up from the lower limb. In terms of umbilical venous catheters, the optimum position is at the junction of the ductus venosus, inferior vena cava, and right atrium, or the DV-IVC-I junction, and is proximally at the level of T8. The acceptability of the position is often dependent on the clinical team, and they may accept a lower position within the ductus venosus, especially if it was difficult to insert, although this comes at a higher risk of extravasation. This slide shows a diagrammatic representation of what we've just seen. The dip that the UVC follows within the umbilical vein is far less pronounced than what we saw with the umbilical arterial catheter. The biggest risk with insertion is that the catheter enters either the left or right portal vein, which vastly increases the risk of extravasation. The clinical team will typically describe this colloquially as that the catheter is within the liver. In this example, look at the UVC and notice the straighter course without a significant dip. The tip sits at T9, T10, which is approximately the ductus venosus IVC junction and is an acceptable location. There is a nasogastric tube within the stomach. Next up, we have the PICC line, also known as the peripherally inserted central catheter or long line. This is typically inserted in a large upper or lower limb vein with the intention of delivering total parenteral nutrition or long-term antibiotics, as the umbilical lines will only remain viable for 2 weeks at the absolute most. In the example on the left, the tip of the long line is projected over the right brachiocephalic vein, which is a large caliper vein and is normally deemed acceptable. In this example, the line has been inserted via the left arm, but instead of coursing towards the left brachiocephalic vein, it has coursed upwards towards the internal jugular vein and will need to be repositioned. Chest drains are typically inserted to drain air or fluid. On the image on the left, there is a large right-sided pneumothorax, and on the image on the right, an intercostal drain has been inserted. There has been a significant improvement in the right-sided pneumothorax. However, there is new right upper lobe collapse. Chest drain position is important, and its effectiveness is dependent on the patient's predominant position. For example, a drain tip that is apical and anterior within the pleural space is likely to be helpful in draining pneumothorax, whether the patient is erect or supine, but would be pretty unhelpful in draining a standard pleural effusion. A lateral X-ray can be useful in showing whether the tip is anterior or posterior within the pleura. A is for airway. If it's a sick child, you may have already assessed the airway when you look at lines and tubes, specifically the endotracheal tube. Sometimes you might skip over the airway if you see something attention-grabbing in the lung, for example, a whiteout or large pneumothorax. But after describing this, your next move should be to go back and describe the position of the airway. Is it central or pushed or pulled to the side of the abnormality? Often in pediatric patients, the trachea will deviate right on expiration, but should not move to the left side. When assessing the airway, you need to trace the entire length of the trachea and both main bronchi and look for evidence of narrowing. The steeple sign of croup can be seen on both AP and lateral radiographs. This is a really nice example of normal buckling of the trachea to the right on expiration. And this is a nice example of the steeple sign. This is caused by tracheal edema in the condition croup. It is not commonly imaged as it is typically a clinical diagnosis due to the characteristic barking cough and inspiratory stridor. We will now cover breathing. The key concepts are listed below, and we will go through each in turn. When we assess lung volume, we are making a general assessment of the lungs. However, this can be difficult due to variability in the degree of respiratory effort. The key questions to ask are high or low volume. If there is hyperinflation, is it generalized or focal/lobar? And if the lungs are low volume, is there an associated area of collapse and does it fall into a characteristic shape? Ultimately, you need to have a look at all of the lungs, including looking closely for a lung edge away from the chest wall that would suggest pneumothorax. The lungs are best considered in zones to make it easier to localize an abnormality. Theoretically, a lesion in the right midzone could be in the upper, middle, or right lower lobe. The silhouette sign has almost certainly been explained to you before, and is actually best thought of as the loss of silhouette sign. It is important that you know your normal silhouettes, in particular which parts of the cardiac border correspond with which cardiac chambers. There is loss of the normal silhouette when there is adjacent material of similar density, for example consolidation, mass, or fluid. In the example on the left, there is right upper and mid-zone opacity with loss of the superior portion of the right side of the mediastinum and to a lesser extent the right heart border, in keeping with predominantly right upper lobe and to a lesser extent middle lobe consolidation. This example shows an intubated preterm neonate. Notice the unossified humeral heads with a nasogastric tube in situ. They have bilateral low volume lungs with granular airspace classification. This example shows an intubated preterm neonate with a nasogastric tube. They have bilateral low volume lungs with granular airspace pacification bilaterally. This is the classic appearance of respiratory distress syndrome, for which low volume lungs is a prerequisite. The appearances may be asymmetrical if the patient is given surfactant, as this is given down the endotracheal tube and may preferentially go down one lung depending on the position of the tube. This is the chest x-ray of an 8-day-old preterm intubated neonate and shows bubbly lucencies in addition to granular pacification with hyperinflation. These appearances are in keeping with pulmonary interstitial emphysema, also known as complicated RDS. Pulmonary interstitial emphysema represents air in the pulmonary interstitium and lymphatics secondary to bowel trauma in patients with RDS on positive pressure ventilation. Also note that there is a malpositioned UVC with its tip projected over the right atrium, which will require withdrawal before use. This is a term/near-term baby born after a long, protracted delivery with fetal distress and passage of meconium. Notice that the lungs are widened with flattening of the diaphragms and multiple streaky opacities in keeping with subsegmental atelectasis. This is the classic presentation and imaging appearance of meconium aspiration. This child is clearly very sick, requiring intubation, and has a UVC in situ with its tip in the ductus venosus. This is another case of meconium aspiration. This baby is very sick, requiring intubation and ECMO. We didn't discuss ECMO earlier as part of lines and tubes because it's still pretty uncommon, but you may occasionally see it if you're at the ICU at the Glenfield Hospital. ECMO stands for extracorporeal membrane oxygenation and is a form of externally oxygenating the blood in patients with severe respiratory failure. On the left-sided image here, we have the chest x-ray of an 8-year-old with severe asthma who presented with acute shortness of breath. There is a veil-like opacity over the left hemithorax. The right hemidiaphragm is usually higher than the left due to the presence of the liver, but here the left hemidiaphragm is at the same level, if not slightly higher, indicating volume loss. These are the appearances of left upper lobe collapse. On the right image, we have the chest x-ray of a 4-year-old with cerebral palsy who has been intubated for respiratory distress and has reduced air entry on the left side. There is a sail-like opacity behind the heart in keeping with left lower lobe collapse. The likely underlying cause in both patients is mucus plugging. Another common cause in pediatric patients is foreign body aspiration. Malignancy is an uncommon cause compared with adults. In this patient, we have opacity in the right upper zone with elevation of the right horizontal fissure, and this would be in keeping with right upper lobe collapse. And on this example, we have loss of the right heart border with volume loss. The volume loss actually appears slightly worse than it probably is due to patient rotation. These appearances are in keeping with right middle lobe collapse. We don't have an example of right lower lobe collapse in this presentation, as it's similar to the previously demonstrated left lower lobe collapse. Let's leave lobar collapse behind. In this example, we have a 5-year-old who presented with wheezing and shortness of breath. There is loss of the normal heart border with a small amount of opacity behind the heart. The splenic flexure of the colon is splinting the left hemidiaphragm, but there is no gross volume loss or a recognized pattern of collapse. The appearances here are likely to represent consolidation within the lingula of the left upper lobe. This example is a chest X-ray of a 2-year-old who presents with a short history of fever and cough. The appearances are relatively unique to children, showing rounded opacity in the right midzone in keeping with round pneumonia. Although the etiology is debated, the most likely cause for this is lack of or immaturity of the collateral airways known as the pores of Kohn. In the presence of a typical history, the patient does not require further imaging follow-up. In this case, we essentially have the opposite of collapse. This is a 2-week-old baby with a history of increasing respiratory distress. There is hyperlucency and paucity of vascular markings in the left upper lobe in keeping with hyperinflation, suggestive of congenital lobar emphysema, and the left upper lobe is the most common location for this. Initially, this area is filled with fetal lung fluid, but as this clears, the more characteristic appearance of congenital lobar emphysema is evident. This is another example of congenital lobar emphysema affecting the left upper lobe, this time with significant rightward shift of the mediastinal structures. This is a similar but distinct entity. Notice the opacification within the right hemithorax with multiple rounded cystic structures. This is the classic appearance of congenital pulmonary adenomatoid malformation, or CPAM. If this appearance was on the left side and more continuous with the diaphragm, we might consider congenital diaphragmatic hernia. Large congenital diaphragmatic hernias are rare on the right side due to the presence of the liver. This is an example of a young, but not necessarily pediatric patient with a right-sided pleural effusion. Notice the classic meniscal appearance of the superior border, which is created by an interface between the aerated lung and fluid. This example shows a more unusual left-sided pleural effusion. Here, the fluid hasn't settled into a classic meniscal appearance, but rather has become loculated against the chest wall. Ultrasound and CT can be used to assess whether there are features of underlying empyema and guide intervention. This is a classic exam film. In this example, there is left-sided white out. We often get asked whether this represents collapse, large pleural effusion, or extensive consolidation. In this example, there is rightward mediastinal shift in keeping with increased left-sided volume, which means that the predominant feature here is effusion, although inevitably there will be coexistent collapse of the underlying lung. This is a left-sided hydropneumothorax, so air and fluid within the left pleural space. When pleural fluid has a very straight line, it typically indicates an air-fluid interface. There is rightward mediastinal shift and also patchy right upper zone consolidation. Clearly in this example, it's obvious that there's air, but the straight line is a nice guide to an air-fluid interface in more subtle cases. Moving on, C is for cardiomediastinal contours. You need to know what the cardiomediastinal borders correspond with and be able to trace them. This is your chance to comment on heart size and shape and assess for both mediastinal and hilar lymphadenopathy. Assessing the mediastinum can be difficult as the AP projection and degree of patient rotation can be misleading. It is important to know your mediastinal lines and stripes, as well as which part of the cardiac silhouette corresponds with which cardiac chamber. This is by no means a complete diagram, as there are both right and left paratracheal stripes, but only the right one is labelled. If there is widening of the paratracheal stripes, it's often a suggestion that there is mass or lymphadenopathy. The paraspinal lines are also present on both sides, left and right, and if widened, is likely to suggest a mass or collection adjacent to the spine. Remember that the right ventricle sits atop the crus of the diaphragm and does not contribute to the normal cardiac silhouette. This slide is similar to the previous one, but shows a superimposed picture of the heart to hammer home the relationship between the heart borders and the cardiac chambers. The left atrium is posterior and does not contribute to the cardiac silhouette, but the left atrial appendage does. When you read a textbook, you will often see reference to a number of different cardiac shapes, and they are all worth learning for multiple choice exams, but in reality, it is very difficult to be entirely certain about what you're looking at. Often the best that we can do when reporting x-rays is simply to differentiate between an enlarged and non-enlarged heart and guide the clinical team towards an echocardiogram, which is likely to be diagnostic. In cases of complex congenital cardiac disease, further assessment with CT or MRI may be needed. This is a massively enlarged heart outline. It may represent cardiomegaly or less likely a large pericardial effusion. Pericardial effusions, the heart tends to look a little bit more globular. Interestingly, there is not much pulmonary congestion or plethora or effusion, and the appearances point towards cardiomyopathy, which was the underlying diagnosis in this case. Here is the classical appearance of tetralogy of Fallot. Tetralogy of Fallot is the most common cyanotic congenital heart condition and is characterized by 4 abnormalities: right ventricular outflow obstruction / pulmonary stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. This image shows the classic appearance of a boot-shaped heart caused by an upturned cardiac apex resulting from right ventricular hypertrophy. This also shows a good example of oligemic lungs as a result of right ventricular outflow obstruction. This case is a really nice example of how difficult and subtle chest X-ray findings can be in cardiovascular disease. Note the subtle dip in the silhouette of the descending thoracic aorta. This is the figure of 3 sign of aortic coarctation. In addition, there is very subtle notching of the inferior surfaces of ribs bilaterally, seen better on this zoomed up labeled view. This is caused by erosion by dilated collateral vessels, shown beautifully by this 3D CT reconstruction. This is my last cardiac example. The 2 images are the same acquisition but have been windowed differently. There is a double heart border, seen best on the more aggressively windowed image, with splaying of the carina in keeping with left atrial enlargement. The other important consideration is the mediastinum. It is essential that we do not miss a mediastinal mass in a child, or anyone for that matter. This chest X-ray shows widening of the mediastinum. There is no loss of the branching structure of the hilum, something we refer to as the hilum overlay sign, which localizes the mass to the anterior or posterior mediastinum. There is no loss of the paraspinal lines, further localizing this lesion to the anterior mediastinum, as confirmed on CT, which shows a heterogeneous anterior mediastinal mass. This turned out to be lymphoma. The classic mnemonic for the differential of anterior mediastinal masses is known as the 4 T's: thymoma, thyroid or enlarged retrosternal thyroid, teratoma, and terrible lymphoma. To be honest, it's not a great mnemonic. At this age of patient, the thymus does not contribute significantly to the mediastinal outline. This image shows bilateral hilar enlargement. The diagnosis in this case was tuberculosis, but other atypical infections and malignancy, including lymphoma, should also be considered. In adults, sarcoidosis would be a top differential. Okay, move on to D for diaphragm. You need to trace the diaphragmatic contours and look above and below. For me, this is a reminder to check the visualized upper abdomen for free air and dilated battle. It's also another chance to look above the diaphragm for basal consolidation or subtle pleural effusion. This example shows gross pneumoperitoneum and also revisits the continuous diaphragm sign as we see it throughout its length. This example is far more subtle, showing just tiny crescents of air below the hemidiaphragms, and is a sort of case where having a system is more helpful. Now we move on to E, which is for everything else. This is a catch-all for everything we haven't previously discussed. In terms of the bones, you need to check every bone on the image. If a neonate has a clavicle fracture, then it suggests a traumatic delivery. So when you see your patchy airspace opacities and increased lung volumes in a term baby, it might clinch your diagnosis of meconium aspiration. You also need to bear in mind non-accidental injury. Research suggests that these children often present multiple times before being identified for a full workup. And spotting an injury could be one of the most important interventions you can make. You look at soft tissues, you're looking for any obvious subcutaneous mass or air. If you see air in the neck, then you need to go back and assess the mediastinum closely for any evidence of pneumomediastinum. Review areas are typically developed from mistakes and can be very obscure. That having been said, there are some review areas that come up time and time again and are listed on this slide. I've seen many radiology registrars struggle with this image, and it is often easier to see what's been added rather than taken away. This patient has bilateral absence of the clavicles and an underlying diagnosis of cleidocranial dysostosis. This image shows the importance of checking the bones. There are multiple bilateral posterior rib fractures in a linear pattern with variable degrees of callus formation suggestive of varying age. This kind of appearance is almost invariably associated with non-accidental injury, typically when an adult grabs a child by the chest and squeezes. This is an oblique view of the ribs showing multiple linear posterior rib fractures, and it's typically done as part of a skeletal survey for suspected non-accidental injury. I won't spend a long time on these views as you will get a separate lecture on non-accidental injury. This is the mirror left lateral view of the ribs, showing again multiple posterior rib fractures and callus formation. In this case, we revisit something I showed right at the beginning of the presentation. If you notice that there is lifting off of the pericardium and the continuous diaphragm sign in keeping with pneumomediastinum, then well done. If not, then review of the soft tissue should reveal subcutaneous air in the right supraclavicular region, which should then lead you to have a closer look at the cardiomediastinal contours and hopefully another chance at picking up the pneumomediastinum. This is a classic review area abnormality. In this case, there is airspace consolidation behind the heart with loss of the normal medial left hemidiaphragmatic contour in keeping with pneumonia. We have now come to the end of our systematic approach. I would like to reiterate that this is best used for the seemingly normal chest X-ray and does have limitations when there is an obvious abnormality. If this works for you, then excellent, but there are lots of other options and you should find something that suits you. I'm now going to show you a couple of cases to test yourself. Pause the video. This is an abnormality that I talked about during the main slides, but I did not show an image. You should be able to start to work this one out if you go through your basic principles. We would normally start with patient details, which have been withheld. This is an AP supine view of the chest and abdomen, taken as a mobile on the neonatal unit when the child was 4 hours of age. The image is technically adequate. There is an endotracheal tube in situ which looks okay. The UAC takes its normal dip with the tip sitting in a satisfactory location. The UVC, though, has gone in too far with the tip sitting over the right atrium. The nasogastric tube is very difficult to assess due to the underlying abnormality. There is bubbly opacification of the left hemithorax. This could be due to a congenital cystic malformation of the left lung. However, there is no air within the bowel in the abdomen, which makes it far more likely that this represents a left-sided congenital diaphragmatic hernia. We normally know the diagnosis before the imaging because of antenatal scans. The degree of aerated lung seen at the left apex is very small and referred to as pulmonary hyperplasia, and is the main source of morbidity and mortality in these patients. Pause the video again and have a look at this chest x-ray performed to check nasogastric tube position in a baby who's presented with failure to thrive. Here we have less information on the image than on the previous study. It is a presumed AP view of the chest. The image is technically suboptimal as the chin obscures the superior mediastinum, upper airway and lung apices. The nasogastric tube, which is the main focus of the study, descends inferiorly in the midline, bisecting the carina and coursing below the diaphragm and the expected location of the gastroesophageal junction to sit within the stomach. The airway, which is less well seen than previous examples, appears grossly normal. The lungs are low in volume, which is likely a result of a poor inspiratory effort. The lungs look busy, which is a result of crowding of the vessels. And there is no focal abnormality as we check our lung zones in turn. There is also no loss of the normal Cardiomediastinal Contours or diaphragmatic contours. The heart does not appear enlarged, and there is no widening of the superior mediastinum, allowing for thymic shadow. There is no dilated bowel or free air below the diaphragm. We're now going to check our bones and soft tissues. Checking the bones reveals a healing fracture of the left mid-humerus with periosteal reaction. This is not an acute fracture, as periosteal reaction doesn't typically occur until 7 to 10 days, and the appearances raise the possibility of non-accidental injury. We'd finish off checking the rest of our bones and soft tissues, and also our review areas, including behind the heart, hilar, the apices, though this is difficult in this case because of obscuration by the chin, and also the edge of film. And obviously your edge of film check would hopefully reveal this fracture if you hadn't spotted it as through your systematic check of the bones. In an exam situation, you would want to succinctly summarize the case. So you would say something along the lines of, this is a frontal chest radiograph of a paediatric patient performed for nasogastric tube position. The nasogastric tube is satisfactorily sited, but there is an incidental healing fracture of the left humerus, which is suspicious for non-accidental injury. I would discuss my concerns with a senior colleague in the first instance. Here is the reference for that case, which was initially performed as a chest and abdomen, and a zoomed up view of the left humeral fracture. Before we finish, let's return to our learning objectives. Hopefully you'll feel like you've made some progress towards all three of these. If you would like to look at more cases, then my best suggestion would be to search for pediatric chest x-rays on Radiopedia and scroll to the playlist section, where there will be multiple playlists with both core and weird and wonderful abnormalities that you can work through in your own time. Thank you for watching.